A very good afternoon. I am Dr. Vignesh, Professor and Head of Orthodontics from Sri Ramachandra Institute of Higher Education. And I'm going to talk to you about the OXIS classification of interproximal contacts of the permanent teeth. I'd like to especially thank Professor Dr. Muthu and the entire team at Sekri for giving me this opportunity. The 6 keys to normal occlusion is the gospel for most dentists and orthodontists specifically, and it was put forth by Andrews. The molar relationship, the axial inclination of the teeth, the crown inclination, the absence of rotations have all been extensively studied, but the 5th key, that is essentially what is known as contacts, or specifically known as tight contacts, has not been extensively studied. So what we did was to study a little more into the 5th key, which primarily refers to the nature of the interproximal contacts between adjacent teeth. It has been proposed that a well-contoured, properly positioned, firm interproximal contact is essential to maintain the integrity of the dental arches and the health of the supporting structures. The contact area in the primary molars has been classified by Muthu et al. As an open contact, which is defined as O, a point contact, which has been defined as the letter X, a straight contact as the alphabet I, and a curved contact by the alphabet S, and thus we get the acronym OXIS, or the OXIS classification. For the anterior teeth, the modification of the OXIS classification as reported by Arthi et al., where the OX and I are retained, whereas the S alone has been modified into S type 1 and S type 2. S type 1 is when any of the anterior teeth is rotated and only one of its surfaces, that is either the proximal surface or the labial or lingual surface, is contacting the adjacent tooth. S type 2 is basically a more severe type where the canine or any anterior tooth is rotated and has 2 of its surfaces, that is the proximal surface, mesial or distal, and labial or lingual surface contacting the adjacent tooth. So you can see the S type 1 and the S type 2 graphic demonstration. However, no such information is available for the permanent dentition. Thus, a classification of the interproximal contacts in the permanent dentition would be the first step to provide more information on the orthodontic implications and importance of the 5th key of occlusion as proposed by Andrews. Hence, we plan to study cast-based interproximal contact area classification for the permanent dentition. Before the start of the study, the single dentist was extensively trained and calibrated on the use of the OXIS classification by the authors of the OXIS classification. We did a pilot study, and based on the pilot study, we came to a sample size calculation, which meant that 8,917 contacts, that is 343 patient casts at the rate of 26 contacts per patient, that is 13 for the maxilla and 13 for the mandible, was the determined sample size. The inclusion criteria was that a full complement of permanent teeth other than third molars should be there. The age range should be from between 14 and 25 years. This was primarily to ensure prevention of occlusal wear and an undamaged interproximal contact. The exclusion criteria was any type of occlusal wear and any developmental anomalies which was seen as in the case of a peg lateral, etc. The contact areas of the posterior teeth were classified based on the OXIS classification. As mentioned earlier, the O alphabet was used when there was an open contact. The X alphabet was used when there was a point contact, mathematically less than 1.5 millimeters. Eye contact when the contact was greater than 1.5 millimeters, and an S contact when the contact area was greater than 1.5 but was curved instead of being eye-shaped. So this was the graphic demonstration of the contact. And we've also shown you study casts and pictorial photographic representation of the OXIS classification. So you can see that the O type means that there is space between the interproximal contact. NX basically means that there is a point contact, and I represents mean that there's a straight contact of about 1.5 millimeters or more, whereas S implies that there's a curved contact which is greater than 1.5 millimeters. As mentioned, the anterior contacts was classified into the S type alone as S1 and S2, while O, X, and I were retained. S, as mentioned earlier, was S1 when the tooth was rotated and only one of its surfaces was in contact with the adjacent tooth, while S2 was used when the tooth was rotated and had two surfaces, that is, the proximal and labial or lingual, in contact with the adjacent tooth. Once again, we are showing you pictorial representations of the maxillary and mandibular anterior region and the associated study cast to show you the OXI and the S type, which was modified into S1 and S2. The scoring, the posterior contacts, the O type was given a 0 value, X as 1, I as 2, and S as 3, whereas the anterior contacts, O and X, O, X, and I were similar. S type 1 was given a score of 3, and S type 2 was given a score of 4. Always the higher value was taken for the scoring. Statistical analysis was then done. A total of 8,918 contacts, which were differentiated into the posterior and anterior contacts, were evaluated. The chi-square test was used to determine the association of contact areas, whereas the McNamara was used to assess the intra and interarch variability. As always, a p-value of less than 0.05 was deemed to indicate statistical significance. The results, you can here see the occlusal photographs and the cast. The upper view is of the O type, then followed by the X contact, which is basically a point contact, and then the I contact, which is about 1.5 millimeters, and S is a curved type of contact, which is greater than 1.5 millimeters. So this is the representative views of the maxillary posterior region. Similarly, the OXIS classification, where you can see the O on the top and the S in the lower half of the slide in the mandibular posterior region, and representative photographs in the maxillary anterior region. Remember, the S type was classified into S1 and S2, while the mandibular anterior region, we have some pictorial representations of the occlusal view in terms of photographs and study casts. These occlusal view photographs were just to understand the association. The study was essentially done on the study casts. The S contact was the most prevalent among the second molar, first molar contacts. The I contact was the most prevalent among the first molar, second premolar contacts, whereas there was a point contact, that is known as the X contact, between the premolars, whereas the O type of contact was the least prevalent. Among the anterior contacts, the X contact was most prevalent, except between the canine and lateral incisors, where there was rotations, that is the S2 type was most prevalent. The least prevalent was the S1 type for the first premolar canine contact, the I type for the canine lateral incisor contact, and also for the lateral incisor, central incisor contact. There was no statistical significance between the right side and the left side of the contacts. However, statistical significance was seen between the type of contacts between the maxillary arch and the mandibular arch. What was of interest to this study was the similarity of the contacts, that is, having the same type of contact in all the 4 quadrants among the posterior teeth was only between 5 and 10%. That is, the similarity ranged between 5 and 10%, and non-similarity was approximately 90%. Further, there was no significant associations which were found for the posterior and anterior contacts when gender was compared with individual quadrants. In other words, there were no male or female differences in the type of contacts, and gender-wise, there was no statistical significance. Previous literature on the primary dentition and on the molars has classified the contacts as open or closed, or as concave and convex, as by Cortes. So our study was the first to classify the interproximal contacts of the permanent teeth. The impetus and the inspiration for this classification was based on the series of studies on OXIS contacts and the reports by Muthu et al., by Kritika et al., Valia et al., Kritika in 2021, and Dr. Muthu et al. In 2021, and the latest modification by RT et al. In 2022. The prevalence of the contacts revealed that the broader contacts, that is the I and S types, were predominantly associated with the posterior contacts, while the anterior contacts were more of the S1 and S2 types. The O type of contact was more commonly seen in the maxilla and warrants further research. Around 90% of the patients had more than one type of contact in different quadrants. We hypothesized that this would indicate that the contact is established by local factors and that the type of contact is an unexplored aspect which may be critical in the development of a single or random carious lesions. The other significant clinical implications of the results of our study are that there could be a role in plaque accumulation and therefore leading to caries formation, as hypothesized by Muthu et al. The I and S type of contacts would be inaccessible for mechanical cleansing when compared with the easier to clean O and X types of contacts. O is basically an open contact, X is basically a point contact, I is when there's a straight contact greater than 1.5 millimeters, and S is a curved contact of greater than 1.5 millimeters. Muthu et al. Have shown that the S and I type of contacts had higher odds of developing caries when compared with the X and O types. The stability of the treated contact would be of significant importance in understanding the phenomenon of relapse in the treated patient, and this is what we are planning to do as a longitudinal study. This would also have implications in force dissipation and transformation, either during orthodontic treatment or during mastication and in routine functions. More importantly and critically, any attempt at interproximal reduction and extraction of teeth for orthodontic treatment would alter the contact and also the type of contact subsequent to orthodontic treatment, which is also one of our long-term objectives. Future studies should thus focus on the long-term stability of the types of contacts, not only following orthodontic treatment, but also during growth and as also during normal wear and tear of the dentition. In orthodontics, there's a lot of controversial literature regarding the relationship between dental caries and essentially fixed appliance treatment. There is a general view among one school of thought that the orthodontic treatment increases the caries risk. That is, in the patient who are undergoing fixed appliance treatment, then the caries levels or the caries risk increases. whereas other authors have felt that the orthodontics, that is basically fixed appliance treatment, is not the determining feature, is not the sole factor in increasing the patient's caries risk during fixed appliance therapy. So, during fixed appliance treatment, we have controversial literature as to whether the caries risk increases or decreases. So, we hypothesize that the type of contact would make a difference to this literature variation which has been observed. With the OXIS classification being a new and interesting classification of the interproximal contacts, it is plausible to hypothesize that teeth with broader contacts, that is the I and S type, and rotated teeth, S1 and S2 types among the anteriors, would be at a higher risk for caries formation in the patient undergoing fixed appliance orthodontic treatment. Therefore, we would like to conclude that the OXIS classification of interproximal contacts is applicable to posterior and anterior permanent teeth. And among the posterior contacts, the O type was the least prevalent and the I was the most prevalent. Among the anterior contacts, the I type was the least prevalent, while the X was most prevalent. These conclusions were different from the deciduous dentition because the permanent dentition essentially does not have spacing as a normal feature. No significant associations were found for the contacts when gender was compared with individual quadrants. The similarity of the contact in all four quadrants ranged from 5 to 10%. These are my references. And once again, I would like to thank the audience for the patient listening to this presentation and to Dr. Muthu sir and Team Secretary for the opportunity to present.